Now the other thing that we need to realize when we're actually looking at the ECG is we need to know what kind of information we are getting from all these chest leads, right? So one very important concept that we must look for is the R wave progression, right? So what is the R wave? So if you look at an ECG, the first positive deflection in any ECG is known as the R wave. Many times an ECG will not have it will not start with a positive deflection, but rather it would start with a negative deflection, and then you will have a positive deflection. The first negative deflection is the Q wave, the first positive deflection is the R wave, right? And then after the R wave, the negative deflection is known as the S wave, right? So you need to keep this in mind, right? And some leads, you don't have a Q wave. So in these three chest leads, V1, V2, V3, you don't have a Q wave. The lead actually starts with a R wave. So what we need to do is, when we're looking at the chest leads, we need to see the R wave progression, and that is that gradually when we go from V1 to V2 to V3, we actually see that this R wave is actually increasing in its size. And towards V6, we see that the positive reflection is the greatest. And there are certain leads in which the positive and the negative are almost equal. So V3 and V4 are usually those leads where the amount of positivity and the amount of negativity is the same, and we call this as the transitional zone. So you have small r's, r is actually increasing in size, but s is still greater, and then you come across a lead where the r and the s are almost the same. Usually it is V4 where this happens. So that's known as the transitional zone, and after the transitional zone, what happens is that you can actually see that the r is bigger and the s is smaller, and then the r gets further bigger. So this is known as the normal R wave progression, right? So when you're looking at these chest leads, you should expect this kind of a pattern. So how can this R wave progression be of some benefit to us, right? Sometimes in certain myocardial infarctions, like for example in the anterior myocardial infarction, there is a characteristic finding that we see, and those are known as Q waves, right? Q waves. Now Q waves are best seen in those leads which normally don't show Q waves, right? So for example, we have V2, V3, V4. These leads can be called as the anterior leads, right? So if you look at these leads, you don't normally see Q waves here in these leads. But for example, if you see this kind of a pattern, if you see this kind of an ECG tracing, in lead V3 and in lead V2, which is not normal because you don't see these Q waves, right? So in V2, V3 and V4, you see this kind of a tracing, where you are seeing, these Q waves being present. That can actually, point out that, this person might be having an anterior myocardial infarction, right? Or it can actually tell us if the person has had a past myocardial infarction, because Q waves are supposed to be one of the indicators of a past myocardial infarction. So if a person has had a myocardial infarction, he has just developed a myocardial infarction, and you don't see these Q waves, you see these Q waves which are not normally present in these leads, then that can actually affect the R wave progression. That is very helpful to us for diagnosis of this condition. Also, another thing that you can actually see, if you have a septal infarction, which might involve the lead V1, what you can actually see is that this normal R wave that is actually present, it will become blunted, right? So this blunting of the R wave, loss of the R wave, and just this QS pattern coming after that, this can also be an indicator of a myocardial infarction. The other thing how this can be helpful is that normally when you compare V4, V5 and V6, you normally see that V4 might have a very very small kind of a Q wave come before the R, very small negative deflection, but V5 might have a slightly bigger deflection as compared to V4, and V6 might have a slightly more bigger deflection as compared to V5. Right, so this is the normal Q wave progression, that as you go towards the lateral side, you see that the Q waves are a little bigger, and this is what normally occurs, right? But if you have this is the normal Q wave progression, but if for example you have V5 with this big Q wave and V6 with the small Q wave, and even V4 has this big Q wave, then you might suspect that there's something wrong. This is probably a indicator of a myocardial infarction, either past or current. So we've discussed how an anterior myocardial infarction or a septal or an anterior septal myocardial infarction can actually affect the R wave progression. But apart from myocardial infarction, ventricular hypertrophy. This is another very important cause of um, a poor R wave progression. So in ventricular hypertrophy, basically what's happening is that the heart, uh, uh, if we talk about the left ventricular hypertrophy, in the left side of the heart, the muscle, it actually increases, right? And because of this, what happens is that the electrical current, on the left side of the heart is now greater. So how does this actually affect the R wave progression? So normally we have the R wave, which is actually gradually increasing in size, and then somewhere around about V3, V4 we have a transitional point where the upward positive and the downward negative is almost the same, and then after V4 we have V5 and V6 which have which are more positive. So if this person had left ventricular hypertrophy, then you won't quite expect this kind of a pattern in V4. You would actually expect very very tall kind of R waves in V4 and even in V5 and in V6. So this would actually point towards that the person might have left ventricular hypertrophy, because normally you're expecting a transition zone, but here uh, you just see that there's more positivity that actually develops, and it's not like a progressive change in the R wave. Similarly, if a person has right ventricular hypertrophy, then you can actually see changes occurring in these leads, V1, V2, V3. So if there's more muscle mass over here, then what you can expect is larger R waves, which are not very characteristic of V1, and in V2 you see these large R waves. Normally we associate these leads with very small R waves, but now if you have right ventricular hypertrophy, you're actually seeing very large kind of R waves in these leads, and which is which is not at all characteristic for these leads. So if you see this kind of a pattern, then you should put right ventricular hypertrophy in your differentials. Now sometimes another thing might occur which would cause poor R wave progression, and that is that lead misplacement. Sometimes the nurse or someone who's putting the leads might not put the leads in the proper way, and that itself can actually be a reason for poor R wave progression. Then apart from this, dextrocardia, which is a condition in which the heart, rather than being oriented towards the left side, it's actually oriented towards the right side. And obviously if the heart is oriented in the opposite way, the R wave progression will not be the same, it will also be in the opposite way. Now apart from these left bundle branch block and Wolff-Parkinson-White syndrome are also causes of poor R wave progression. We won't be discussing these in detail, right? Then there's a normal variant. In some people, the poor R wave progression just could be a normal variant, right? Now here you need to understand some terms. Now we've already discussed one thing, and that is that normally, if you look at the chest leads from V1 to V6, you can actually see that the R wave is gradually increasing, and then round about V3 and V4, you have the transition point, and then after V4 and V5, the R wave is greater than the S wave, right? But some people, what can happen is that the transition point comes in early, right? Transition point comes in early at around V1 and V2, and after V1 and V2 you actually just see a greater, bigger R as compared to an S. So the transition point comes in early. So if the transition point comes in early, we call this as early transition. The other terms also used as rightward shift, or counter clockwise rotation, right? So this is a normal transition, this is an early transition. This kind of a pattern is now coming in V1 and V2, right? So similarly, just like this, what you can actually see is you can see a late transition as well. So in some people, what will happen is that the transition point will occur somewhere around about V5 and V6, right? So V5 and V6 will show something of this nature, right? And this is known as a late transition, leftward shift, and clockwise rotation. Now, so what's the importance of this? Right now, this could be a normal variant. So in many cases, even if you have an early transition, it can be a normal variant, and basically, what it tells us is that the heart is actually rotated in a counterclockwise fashion. In many cases, this could be the cause of the early transition. So in some people, uh, the heart, might be a little bit rotated to in the counterclockwise position, and that's why you can actually see a early transition. A late transition could occur because the opposite, the heart is actually rotated in the clockwise direction, so that might actually cause a late transition. In some cases, this could be due to a disease, like for example, clockwise rotation could be due to COPD. COPD causing the heart to rotate in a clockwise way. Yeah, and late transition could be because of apart from rotation, it could be because of an anterior myocardial infarction, or or perhaps heart dilatation. So these are some causes of late transition. Now early transition could be due to posterior myocardial infarction, or perhaps due to right ventricular hypertrophy, right? So it's important to keep this in mind, right? The one last thing that you should know is that sometimes it's difficult to locate the transitional point. So you don't quite find a transitional zone of transition, and in these cases, very likely to be pathological, right? So keep that in mind.